Here.
All right. Well, I guess we're live. Do we have audio? We're checking on the audio, but welcome to Journal Club, January 17th, 2018. Dr. Merlin couldn't make it today, but we have a lot of great articles. We have the fellows here. Fellow just came back from San Diego, the EMSP conference. They also took the medical director's course there. Some good stuff. Anything interesting that you learned from the conference, guys? Anything good? I know that HR 304 was passed, the bill. We talked about that on previous episodes, where it's access of EMS personnel given narcotics to patients in the field. So they're working on actually how to make that a reality. So any interesting cases? Again, no hospitals, no names, no identifying information. I guess we've been away for the entire week.
Yeah. Not so many cases because we've all been gone. None come to mind.
All right.
I had one interesting case. It was just a atypical presentation. I mean, I had a young female patient that came in, probably in about her 30s or so. She was complaining of some abdominal pain, and that was her chief complaint. Initially, she came in. Her vitals were, her blood pressure was around 115 or so, over 70. Heart rate was 115. Oxygen saturation 98%. And her temperature was normal. I think I'm forgetting a vital sign. Blood pressure, heart. Maybe I got them all. I don't know. Anyway, she was pretty tender right upper quadrant on exam. For some reason, she got an EKG, which showed somewhat right axis deviation a little bit, which seemed a little bit atypical. Really not complaining of any chest pain or shortness of breath. I was working in a hospital with residents, and the resident said to me, "I think this woman has a PE based on the EKG." I'm like, I mean, yeah, I guess based on the EKG with the right axis is definitely a possibility, although she was very tender in the right upper quadrant, so I felt that kind of, led more towards gallbladder disease rather than PE.
So sinus tachycardia, S1, Q3, T3 on EKG?
Yeah, there was, I don't think there was no S1, Q3 or T3 on the EKG. It was just sinus tach with the right-ish axis. So, we sent labs on her. Pretty much everything came back normally. Did a right upper quadrant sono, which also was, we did a bedside sono, which didn't really show anything. It was overnight, so there was no ultrasound at the hospital I was working at. So we decided to scan her because she was very, very tender. It came back that she had a right-sided pleural effusion there, which we weren't really seeing on a chest X-ray, and the radiologist commented this could be related to PE. So at that point, she had just gotten scanned in contrast, so we didn't want to scan her again. So we just empirically, anticoagulated her at that point and admitted her, waited for a CAT scan for the morning. And it turns out she did have a small subsegmental PE. So I don't know, it's just interesting. I don't know if you guys have seen PEs presenting with abdominal pain and tenderness. It seemed a little bit strange to me. I'm still not convinced that kind of explains the diagnosis, but I don't really have anything else that it could have been. So it was just an atypical presentation. And yeah, I don't know, just where does it leave us to think, for the next time something like this comes in?
Yeah, so just the fact that the right-sided pulmonary edema is right on top of the diaphragm, that can cause the abdominal pain from referral pain. Unfortunately, I diagnosed a lot of pneumonia on abdominal CT, not mine, but someone would admit to my service for an abdominal scan for abdominal pain. Yeah, the EKG findings, we find that 10% of the time you have that S1, Q3, T3, and what it comes down to is history and physical. You have that feeling that it was that clinical gestalt, that it was a PE, and pointed you in the right direction. Yeah. Did you have something?
I mean, it was just one small subsegmental.
Yeah.
Sorry, I was wonder. I think there was a good chest review a year or two ago that it was basically, do we really even need to treat these subsegmental, even if it's multiple subsegmental, because they're small, they're not affecting the hemodynamics, and likely these kind of come and go and we just resolve. I mean, it seems weird. Like, was that enough to cause a rightward axis and stuff?
Yeah.
I don't know. Maybe it was just incidental and we never explained her abdominal pain, and that's what makes medicine hard.
Yeah, I'm not really sure.
Rather than trying to,
Yeah, I haven't been back to that hospital. I just heard from the resident there, so I haven't been back there since. But I'll be there the next week or so, so I'll follow it up and kind of get a better idea. It was just interesting. I thought.
Well, some people say that the lungs were created just to filter out these small PPs, so
yeah,
it was doing its job. Any other interesting cases? Interesting presentations on cases that were.
I mean, we had a cardiac arrest that we went to. It was unwitnessed arrest, downtime of approximately 10 minutes prior to 911 being activated. So we ended up getting there. Obese male, big beard, edematous pretty much all over, history of heart failure is all we can gather, hadn't been feeling well. Got an IO, the medics intubated him, and we were on doing compressions for about 8 minutes. He'd gotten his epi, did cardiac ultrasound, there was no cardiac motion, and I went to go talk to a family friend who was around and pretty much said, hey, we're getting ready to terminate efforts here. And in that 2 minutes that I was gone, sure enough, we get a pulse back. By the time we get him back, and by the time we get ready to transport him, he's got atrial fibrillation anywhere from about 115 to 160s. Blood sugar was fine. His end-tidal CO2 was in the 90s. But ended up getting him back, and ultrasound showed pretty good contractility. Even with that long of a downtime, his pupils were still somewhat reactive. I mean, they were sluggish, but they were reactive, even with that long of a downtime. So we ended up getting the EKG, and it was just AFib, no ST changes until we were en route to the hospital. Got a little bit better look, and it looked like, to me, it looked like a STEMI to me. He had the reciprocal depressions, looked like a lateral MI, and with his history and cardiac arrest. So I went ahead and activated, informed the hospital that we were headed to, that was what's going on. And by the time we were there and were given a report to the docs and the nurses, they repeated a 12 lead. They ended up doing 2 separate 12 leads, and you can just see the EKG changes evolving during the time that he was just in the emergency department. They were hesitant on whether or not to activate cath, but they ended up, I believe, doing so when we were getting ready to leave. But it was just kind of a thing that stood out was just that goes to show, we talked about, do you take these patients to the cath lab after ROSC, and the evolving EKG just helps kind of prove that this was probably an appropriate patient. He had pupillary response, whether or not neurologic outcome, I don't know, but with that kind of history and having these evolving EKG changes, it started to look like a new left bundle by the time we left, is what it started to look like.
Yeah, important things from that case were the repeat EKG. Having 0 EKGs, you can see actually evolution of changes. If you do one EKG and do one 15 minutes later and look exactly the same, that tells you that, it's not changing that much. Do another one 15 minutes later. But if you do one at time 0, one 15 minutes later, and it's a completely EKG, first I'll just make sure it's the right patient. But if you have strong suspicion that this person's sick, that something cardiac is going on. This one declared itself by having a cardiac arrest. And actually a lot of things were going against us. So does anyone recall the 5 things for successful CPR? What are the best indicators? 1, witness arrest, so he was unwitnessed. But actually in this case, someone had been talking to him 10 minutes prior. So similar, immediate CPR. End-tidal CO2. Do you recall the end-tidal CO2 for that patient?
It was in the 60s during CPR, 50s and 60s during CPR.
I mean, even during CPR, 50s, 60s are kind of high. So the next thing you have to think about is, are they actually having a perfusing rhythm that is just the blood pressure is too low that we can't palpate pulse? Doesn't matter if we can't palpate a pulse. should we continue to do CPR to increase that kind of flow? These are questions that are unanswered right now. We have the benefit of having ultrasound on our physician vehicles. The initial ultrasound showed poor cardiac motion. When we had the repeat, when we had this kind of like PUA kind of a rhythm, we took a look at the heart and there was actually contraction. It wasn't great contraction, but it was contraction, more than you would expect with just epinephrine. So that's when we started the epinephrine drip. And by the time you package the patient and bring them into the ambulance, we had a good blood pressure. Unfortunately, in the house, you can't really palpate a pulse, but you can see it on ultrasound, starting the epi drip, and with all that, we got a pulse back. We didn't actually need any additional CPR. The other thing with this case is, should we have ultrasound in the field? I mean, it would really help in our clinical decision making, as well as, differentiating dyspnea. Is this CHF? Is it not CHF? Things like that. That's a bit of a tangent, though. Did anyone else want to comment on the case?
But I think even, just in general, patients like this that don't necessarily declare themselves as a STEMI, somebody with favorable, prognostic factors in cardiac arrest, short downtime, early defibrillation, underlying VFib, VTAC, things that favor ACS with a non-STEMI on EKG. I think even that's a patient population that, we're still sort of on the fence about being aggressive with earlier intervention and everything as well. And I know there's a good paper from Journal American College of Cardiology by Rob that outlines like an algorithm for those patients as well. And so if that patient shows up in the department, is that somebody that would benefit from PCI?
Yeah. Some of the things that you mentioned that are very important is the initial rhythm. So for him, our initial rhythm was asystole, which is poor prognosis. Good prognosis is VFib, VTAC, shockable rhythm. So when I am going to a cardiac arrest and I hear that, the AED has gone off, that's telling me that he had either VTAC, VFib, something going on that gives this a more heightened level of, like, we could get this person back. We are proponents of pronouncing on scene if medically necessary or medically futile to continue effects, especially because, transporting a body, doing CPR, doing all these life-saving heroic measures is dangerous. What if you get into a car crash on the way to the hospital? What if, you have to brake hard and someone gets thrown in the back of the ambulance? These are very dangerous things, and, if we can prevent that, that is much better. And we're doing everything in the house that we would be doing in the ER, so.
I think tying it into some of the stuff that we touched on at the NA-EMSB conference, it's like there's like the effort in Paris where they're using ECMO in the field for these cardiac arrests that have initial vitality, and showing actually pretty good results. And then the second in Minnesota, the Minnesota Resuscitation Council or Consortium, they basically are doing something similar where they're putting these people, if they're trying to get quick shocks, quick CPR. If you don't have a response after 3 shocks, they're putting you on a Lucas device or another mechanical CPR device and taking you straight to the cath lab. And all these patients are getting cath. And they're having some remarkable numbers out of it. I was just looking at the numbers a second ago. They have, so far, have had about 102 patients that have basically had this refractory refib. And then they've had 47 of those 102 survived a hospital discharge. 42% of them have cerebral perfusion scores of 1 to 2, which is like great functioning, normal, walk in the hospital, and true heroic story. So I think maybe that's something that we should be doing more and more. Certainly something that we're kind of looking at on the national level is, should we be taking all cardiac arrests that have some viability factors to the cath lab? I know that's sometimes in certain states, certain hospitals, there's a little bit of a pushback from the cath lab, both from a resource perspective, but also from a lot of the ways these numbers are calculated by cath labs. They get dinged if there's deaths when maybe that's not the best performance measure, because a lot of times it's a heroic cath. And they're having really good numbers in Minnesota, so that's...
Oh, that's exactly, you touched on all the points that are very important. The problem is that cath labs are judged based on how many deaths they have, but I would feel that those are the patients that you want to take, that you want to give them their best chance at surviving. And those numbers, those are the outcome measures that are important to us. We want these people who are having cardiac arrest to walk out with very little deficits, living regular lives. And those are the measures that I think matter the most.
And a refractory VFib is often from a cardiac cause. It's a coronary vessel cause. That's why they're still stuck. That's why that myocardium is so still fibrillating.
And I'm very excited to see their final data, and I hope they are able to push it out. I think I talked to the authors. It was either in that study or there was another study, and the way that they were able to do it is that they have 2 hospital systems, and that's it. And the 2 hospitals, and they basically say, well, they're taking these to the cath lab usually too, and I'm guessing that their state doesn't have the reported measures that, deaths as well, so that's how they were able to get this.
They had to get a lot of hospital support too, because now you need ECMO teams, you need your cardiac surgeons involved, so they had to make kind of pledged from a hospital perspective of, listen, we're going to support your EMS system because we think this is important, and this might really change outcomes. At least preliminary data shows that it is having a profound impact.
And the biggest thing that people talked about with this specific cost is to put someone on ECMO, you're committing to like $10,000 a day. These are $1 million patients. When do you take them off?
Right.
So this is a problem across the country where we have people who are on life support who have already passed, but we're artificially keeping them alive.
Right.
And at a cost of $10,000 a day, unfortunately, like you want to think about resources, and someone else needs that bed.
Some of the smart things I think they built into the protocol, though, is before they even started, these patients were started in cardiac arrest. They're getting not the usual care. They're getting this experimental limb of care. And when they built in that protocol, there's ECMO time limits. You get, I believe, if you had a clean cath, no identified lesion, you had a certain time period of 30 minutes or an hour of ECMO. Same thing if you had an identified cath, you had a little bit longer time. But either way, there's a hard time limit, and that ECMO goes off, pulse or no pulse, at that time limit. And I think that's one good way to control the cost, but we'll see.
So for one of the biggest kind of studies that's come out is through the cardiac literature, which is on Heart Online Journal. Nerlo and Webb and McCarthy kind of put out this publication on out-of-hospital cardiac arrest and kind of some of the future perspectives. And this was published in 2015, so it's a fairly recent study. We obviously know the class 1 recommendation for STEMI is PCI, but then for the most part we had early introduction of like hypothermia protocols, and we kind of know that's kind of fallen out of favor, but that's also kind of out there. But risk stratification for patients getting PCI out-of-hospital cardiac arrest with ROSC is very sparse. But when you look at the literature, it's really cool that you actually see that aggressive management of these patients is actually pretty beneficial. And we know that when we talk about early PCI, and when we talk about early PCI, what we're saying is that PCI intervention within 72 hours really increases survival. And so that's how we do the NSTEMIs. These NSTEMIs we do within 72 hours because we know there's increase in survival, increase in neurological outcomes, and those patients especially specifically dealing with out-of-hospital cardiac arrest, we know survival increases from 26 to 61%. But then when we look at the subset of population, you do them earlier, so like less than 24 hours. So patients who actually get PCI less than 24 hours from admission of out-of-hospital cardiac arrest that don't have a STEMI on their EKG, now we're talking about a different subset of population, and the overall survival in their study was basically 58% versus 30%. That's huge. And these are all patients with improved neurological outcomes. So we know that moving that bar from 72 hours to 24 hours makes a dramatic impact. And we're actually seeing better neurological outcome with early PCI. So this publication was really great because one, not only did it kind of establish that early PCI is important, especially within 24 hours. Now the next question is going to be, well then, what patients can we take right away as soon as they come in through the doors? And they created an algorithm which is really nice in this publication. The algorithm kind of basically talks about looking at the patient that has favorable resuscitative features, and kind of what Navin pointed out: unwitnessed cardiac arrest, initial rhythm non-VFib, no bystander CPR, greater than 30 minutes to ROSC, ongoing CPR, a pH of less than 7.2, a lactate greater than 7, age of greater than 85, end-stage renal disease. All of these things are poor predictive factors. But if you get someone with witnessed cardiac arrest, initial rhythm was VFib, and you got someone who's got, bystander CPR performed, and they've got good lab values, this is a patient that could probably benefit from early PCI. And that's hopefully where we're going to get the buy-in from a lot of centers to do this. And it's just a matter of kind of getting more up to date with the literature and getting our PCI team more involved and kind of engaging in these discussions.
Any other interesting cases? Anything anyone from NAUSP?
One of the cool things that we heard at NAUSP was Singapore, what they're doing, which I just thought is like amazing. They have like an app basically. I know we have an app here, but it costs a lot of money to get on, at least for the cities. But they have an app basically you can sign on to if you want to be a CPR first responder or AED trained, and they basically train everyone for free in CPR. They have taxi drivers that are going around with AEDs, and if there's anyone in the vicinity, they basically just get a signal sent to the app, and they can respond. And it's just like incredible. They're putting AEDs in like every high-rise building now, and it's dramatically increasing the amount of people that are available and the amount of time, and decreasing the amount of time it takes to get a defibrillator to someone in cardiac arrest. They also have these like little cards that measure the quality of CPR that's done, that they can get the data off of after to see how effective the CPR is, how if they're compressing well enough, that the rate is well enough. So it's amazing what they're doing. I mean, it sounds like, I think it's like all government sponsored. So when we're here in the States, it comes down to a money factor. And there is some apps that are out there now to get people, to get CPR trained people. But right now, from what I understand, it's only people aren't, the app doesn't send people to people's homes. It's only if someone is in cardiac arrest in a public setting, and it also costs thousands and thousands of dollars for whatever municipality to pay to be on the app. I think it's free for the responders to log on or get the app, but someone's got to pay for it on the back end.
Yeah, I'm not sure about the cost, but I think our Jersey City colleagues, they have some sort of app that's enabled, and it's an opt-in where you can register yourself as a CPR certified, and then as a business or even as a home, you can register your AED. So let's say we're in this building, there's an AED next door, and there's a cardiac arrest in the parking lot. You'll get notified that the closest AED is next door, and the person's right there, and that you're like within 30 seconds of them. The good thing is that, yeah, you can get on the chest very quickly, you can get the AED very quickly, but at the same time, if the person next door didn't register their AED and it's there, you really wouldn't know.
Right.
The early research with kind of these kind of systems, I think the big one that comes to my mind is like the Chicago airport. They basically said no matter where you are in the airport, you should be able to see 2 AEDs. And no matter what, you should be able to get it and bring it back within a minute or 2 minutes. Something like this is like 5-10 years ago. And they had such good outcomes that I think San Francisco, they put AEDs on every municipal vehicle. So garbage truck, police car, and they would get dispatched for cardiac arrest.
I like the garbage truck on lights and sirens to the calls. That's awesome.
Well, they wouldn't go to lights and sirens, but whoever's the closest AED would be dispatched to divert to.
I think it's true. I mean, I think we have an issue. I mean, we train people in CPR also. How effective? I question always how effective our training is for the layperson in CPR who takes a course for 6 hours or 8 hours for one day. What's the retention? A day out, 2 days out, a week out, a month out if they haven't done any CPR. It costs people a lot of money, so people aren't so inclined to necessarily pay for that. And we see these other systems where people are getting trained for free. They're condensing these courses into an hour or 2 hours, and it's minimal amount of time, and they're getting so many people out there that are trained in this. I mean, we focus so much on cardiac arrest, which I think is great because we can definitely save people's lives. If we get there quick enough, and I think one of our biggest problems with cardiac arrest is that we're just not there fast enough. And I think if we look at the systems that get people there within minutes, those are probably going to have the highest rates.
And that's the reason why the research in CPR cardiac arrest management is so diverse, is because you can't just say like, where's this cardiac arrest going to happen? We just don't know.
Yeah.
And I feel like we should separate our patients in cardiac arrest, witness arrest, unwitness arrest, and those are two drastically different patients. Because the unwitnessed arrest that no one's seen for 7 hours, they may have, there's almost zero chance. But the patient who you're talking to and then now they're on the floor, they have the best chance.
Yeah.
Forget what I was going to say. All right. You want to start on the articles? Sure. And whatever I wanted to say will come to me at some point. Maybe not. Drew, you want to start?
Yeah, I guess I can start with one of the articles. We had kind of a bunch this week. The first one, I guess, would be the pre-hospital use of glucagon. So this was a letter to the Annals of Internal Medicine, basically, kind of giving a current situation report of the nationwide use of glucagon and then some of their recommendations. They kind of went into a background of this is a really costly problem. It's a common problem, as all you guys know that respond to calls, right? These diabetic emergency calls are very common, very frequent. And then once you get into the emergency room, the emergency room bills are frequently $1,500. Hospital stays are in the tens of thousands per day. So when you add all those up with all the frequency of calls, it becomes a big issue. So this researcher actually looked through the National EMS information system from 2013 to 2015 to try to kind of pool all these calls, identify kind of whether they were real diabetic emergencies, where they identified that by the dispatcher, and then where they dispatched and kind of what happened. It was a lot of calls. Let me see if I can find the actual number. 89,263 calls in just those 2 years. About dispatchers correctly coded for 44% of those calls as a diabetic problem. Others came in as something else, often from the bystander description that can mislead the dispatcher. And then there was, out of those 89,000 calls, there was 3,900 calls where glucagon was administered, so a very relatively small proportion. And so this researcher was basically saying, with the massive scope of this problem and the cost of this problem, why is glucagon being used so little? And so they wrote to each of the state EMS directors to kind of get some of their data to see if they had any protocols. And then there is a chart in the article that we have posted that basically shows each of the states and kind of what do they have. Do they have BLS providers able to test blood glucose levels with a glucometer? Do they have BLS providers able to give glucagon with or without that test result? Do they have no ability for a BLS provider to do any kind of diabetic intervention? And then do they have no protocols, which that only one, Texas, has no protocols. I guess they don't just speak to the subject. Interestingly, New Jersey is one of the states that this researcher lists as no statewide protocol for BLS glucometer testing and no statewide level BLS glucagon use. I know individual agencies have a little more leeway. The same with many of the other states. There's a couple of the states, especially in the Mid-Atlantic, that have both glucagon and glucose testing for all their BLS providers. And although they don't have a lot of the outcomes data to say whether this is effective or not, this is kind of a letter to the editor saying maybe we should be doing this a lot more. Glucagon has a pretty high safety effect. If people, especially diabetic family members or office, primary care doctors, can maybe recognize this patient as diabetic, give them glucagon. Maybe they don't have the resources for an IV or a dextrose or the time, but if they can, self-administer glucagon by the time EMS arrives, they're now better, they can eat, they can kind of self-control. That might be a way to improve outcomes, decrease all these costs, and especially with the relatively safe drug of glucagon. And I think the same thing, the other part of their argument is why are BLS providers not able to check blood sugars? That seems kind of like a pretty easy intervention. There's a cost factor associated with the devices, but maybe that cost is less than the cost of all these other hospitalizations and bad outcomes from these diabetic patients who have this. They mentioned that Medicare the cost to Medicare for a glucagon prescription to a diabetic patient is only $200, much less than an ALS response, an ER visit, a hospitalization. So maybe we should be using these like we have EpiPens, right? EpiPens are in pretty much every school office. They're in lots of public buildings. We're getting to the point where like EpiPens and AEDs are kind of publicly around. And Narcan as well. Should glucagon maybe be that same kind of category? No, that's a good question. I think it kind of makes sense, right? You give someone who doesn't need glucagon, well, more or less, they're okay still.
So we don't usually test for glucagon, but we test the glucose. And one thing that may come is, have you had anyone who had severe nausea, vomiting with glucagon? So that's one thing that might, that's one side effect. The other thing is actually drawing up the medication, delivering it with an IM shot, which, you know, maybe the school nurse can do it. Not sure it can be done at home.
Pre-fills.
Pre-fills,
They
yeah.
come, they come,
That's true.
We carry it as a pre-filled syringe.
But we have to mix it, don't we?
I thought the dilute it.
Yeah.
But it's
Yep. I mean, I carry glucagon with me. I have it in my first go bag because I try to condense as little as possible into my walk-in bag that I can. And, you know, for a patient who's diabetic, altered, and stuck somewhere, I would much rather have them walk out than have to carry them out. Or because sometimes it's just very difficult to start an IV in cramped spaces.
our main issue with this is OEMS is always considered obtaining of blood glucose as an invasive procedure. It's outside the scope of practice of an EMT.
So that's the other issue I was going to address, is that it's based on the agency, then the state level regulation. On the federal, I don't think there's anything against them doing it.
yet.
But I can have a security guard do a blood glucose on someone because we can do blood glucoses at home. But because an EMT, paramedic, other healthcare providers are regulated, you actually have to have testing, you have to have credentialing. Often when I was an EMT, we were taught to help assist them test their own sugar.
Right, which is ridiculous, of wrangling around the politics of all this stuff, right? It seems so silly in the modern day and age. And many of these devices are as simple as you put the pin, you push the button, and you put it there, and like it's all automatic, especially some of the reusable ones. And if we can teach patients how to do this at home, we certainly can teach our medical providers. Right, we have kids at school, in elementary school, that check their own sugars. And, you know, it's maybe it's not in our national interest, and I think that's the point of this letter, is to advance the conversation.
Yeah, I think in the future it will be, but just not right now in the current. Because one of the things I can foresee is, you know, you have these automatic testers, and, you know, you are taking blood from someone. What happens when you expose your EMT or your firefighter to blood? Like the lancet shoots out by mistake, and you just get it from them, and now you just inoculate yourself with their blood.
Right, but probably not so different than a car wreck where there's blood all over the windshield and you're dragging this person through broken glass, and we are like to you know, it's just like a silly, like, national social practice thing that I thought was ridiculous when I was an EMT, which made me want to go advance through medicine, because some of this stuff just gets silly. And we're harming people, right? At the end of the day, we're harming people, we're driving up costs. And I think it's not in our best interest. And this is probably a good, relatively safe intervention.
But expensive.
But expensive. That is the downside, right? It is expensive.
Any more comments on the glucagon? I remember what I wanted to say before. So one of the things that, you know, as a public health policy, some places they have CPR as a required class in school. So I know when I was in New York City, as a high school student, every high school student, there were a lot of drownings because, you know, being in the city, you didn't have to swim a lot. So in order to graduate from high school in New York City, everyone had to pass a swim test. And dramatically, all the drownings went down. So, and there's some places where they say, you know, in order to graduate high school, you need to have a CPR card. And that, at a baseline, at least, it will take 10 years. But then you have a population who knows how to use an AED, who knows the basis of CPR. Even if they haven't taken a CPR class in the last 10 years, the dispatcher who says, all right, can you put your hand on the patient's chest? Exactly, it's familiar.
Yeah, I mean, I think the other thing is it varies so much by state in terms of what kind of exposure people have to CPR or any kind of, whether it be CPR, BLS, whatever they do in terms of their CPR training. I know not been brought up schools, but I mean, in a family who are teachers, they don't get any, they're not required to have any kind of training whatsoever. Not every school can afford a school nurse. So you may send your child to a school where, should something happen, there may not be anyone around that knows how to perform any kind of CPR or anything, has not had any training. And then, I mean, a family member, a young kid had SVT at school, told the teacher, hey, I'm not feeling well. And they said, I don't know what to do, call your mom. And that's the answer. So they had no training whatsoever. They don't know how to deal with kids that may have these things. So not only is it that some of the kids, high school students, should learn how to do it before graduating, but even just from the school board and kind of public health perspective, educating some of the educators, whether it be a few people in the school that are dedicated to know how to do CPR, and then somebody's there on a daily basis. Is the school nurse always available, or do they rotate? But just something to keep in mind from a public health perspective in terms of accessing care. I know it's kind of off the glucagon topic, but I know kind of going back to the resuscitation, CPR.
It's the same public health issue, and there are some school districts who have that everybody employed by the school district has to be CPR certified. I don't know which districts those are, but I know that there are some who make that a priority. Next article. Chris, did you want? Article?
I can go.
All right.
So we can do the transition of care, since I know we kind of talked about. We've been kind of talking about some of that. Once I can find it. Where's my transition of care article?
Yeah, so this goes along the line of like SBAR, transfer of care of patient from paramedic to the ER, from the ER to the ICU, ER to private attending, to be admitted to the hospital. And these changes of care are very important because you were with the patient for 30 minutes, 10 minutes, an hour, transported to the hospital. You have a wealth of knowledge, and that shouldn't just be ignored.
Yeah, I was just saying, we'll get into the article here in a second. I know we talked about it. We talked about it before in terms of kind of discrepancies and kind of butting heads between receiving hospital staff and paramedics. You didn't call, and paramedics sometimes can feel like they're kind of taking a little bit of a beating when they drop off a patient. So this will kind of go into that exchange. This article is specific between the paramedics and emergency department nurses, but again, patient handoffs and transitioning care happens multiple times throughout a patient's hospital stay, starting from the pre-hospital experience. It actually starts from the first call to 911 to that dispatcher. Once that call gets received, the information given to that dispatcher then sent out to the medics. That is the very first transition in care, even though it's not something that's traditionally thought of as such. So this article is it's a systematic reviews article, so this is kind of just a Department of Nursing, Faculty of Nursing from the University of Calgary, pretty much saying that they want to do a large systematic review. So one of the things that it brings up is kind of what are the current issues, and then what are some potential things that are being done. So this defines it pretty much that transitions of care, these are complex processes. Information can be lost. Vital signs are just one part of it. There's a lot of information that goes with it. So it has to be effective communication, and it has to be between different levels of service providers. So the nurses may not have ever been paramedics. Paramedics may never have been nurses. So that's one of the factors that could kind of impede this transition process. So it talks about efficient and safe transfers and care dependent on accurate communication of pertinent information. Some of the factors that they discussed that can hamper this handoff are multiple interruptions, so the nurse is trying to get this, get that, run and do this, trying to hook up the patient on the monitor, and not actually dedicating the time to listening to that report. There's multitasking that occurs. The significant workload We have a nursing shortage. We focus on the physician shortage. There's a huge nursing shortage as well. So you may have one bedside nurse that is running around. She just got 3 new patients and now has a new ambulance and just got 2 from the front. So the workload is increasing for all levels of providers in that pre-hospital, in the hospital, and everywhere else. And then the suboptimal working relationships. So the reason this comes into play is because it can negatively impact patient safety. People can overlook some major concerns, and then there's potential bias when these handoffs occur. So going through it, it's pretty much one of the important things is that the different training the paramedics have are taught to assess the scene, figure out what's going on, provide treatment, and get the patient to the appropriate destination, while the nurses kind of focus on their throughput and their workload, and also allocating treatment spaces in terms of charge nurse and receiving nurse. So essentially what this study looked to do is perform a large systematic review of mixed studies on multiple methods that focus on that transition of care, wanting to assess factors that can mitigate or improve these actual transitions. So the questions that they were really looking at are what factors might mitigate or improve transition, and what are some potential interventional strategies that can help improve these transitions. So some of the things they discussed that from their studies are that they're looking at are standardized protocols for handovers, checklists, mnemonics, automatic electronic data transfer, and then communication skills training for different levels of providers. So they searched multiple databases, or their plan is to search multiple databases, and then provide a reference listing to that. And the article lists a bunch of the keywords that they're using to help identify these. So there's not, and when kind of going through it, they're looking at multiple different things, but this is a plan to do this large systematic review. So there's no concrete data saying this is what you need to do and this is how it needs to be done. But pretty much their review findings are aiming to potentially impact the design and development of new protocols, structures, and ultimately with the goal of improving patient safety. So standardizing the approach to these transitions is really something that needs to be focused on. This actually also came up at NAEMSP. There was a lecture that was given about the culture of safety, and the lecturer was from Pennsylvania, and one of the things was the state of Pennsylvania, through the Department of Health, has actually posted a patient handoff form that can be completed by EMS. Takes 2 minutes in addition to the verbal report that is left at the patient's bedside with that nurse. That nurse may just be the triage nurse, and someone else would be the primary nurse, but having that one written form of communication that's left with the patient. I know the system where I came from before, where I did residency, that was part of their protocol that was initiated kind of the last year of my residency, was that it's a one sheet of paper, pretty much chief complaint, allergies, meds, pertinent medical history, set of vital signs, and then any interventions that were performed by EMS. It took 2 minutes, and then they took a copy. It actually helped EMS with their chart later, but it also provided extra information to the staff that was receiving the patient. So it's not integrated in every system, but I think it's something that we really need to consider in terms of education, patient safety. I know hospitals are always focused on this relationships between providers and communication. I don't see why it should be all that much different for pre-hospital personnel.
Yeah, I think on what you said, it is awesome that they do that there, and I think it's a very easy intervention we could bring to our system, or really any system, and I think it makes a huge difference in the patient care, especially now in the era of electronic medical records. Stuff is just not getting left for the patient. Charts may be getting transmitted within 24 hours of the patient arriving in the ER, but we're asked to make a decision about what their care is within 5 minutes. We stand there in resuscitations, and if you ask everyone in the room to repeat the vital signs that were just given to you by the EMS providers, how many people are going to come up with different numbers? Probably pretty much everyone in the room. There's so much stuff going on, it's impossible to remember every medication, every vital sign. Sure, we'll probably remember in the area of what was going on. But, something that I do in my own personal practice, when I'm running a resuscitation, I stand at the foot of the bed and I'm just writing right on the bed sheet the vitals, the medications that were given. That way I know that it'll be right next to the patient when I'm going to go do my next intervention, and that it's there, and I know exactly what EMS said. Because that time, And there is some research about this. We talked about this like back in September, I think, at one of our meetings, about the variability of the information that's getting communicated, and it is highly variable, and it does impact patient, and it does impact the patient, and it is essential, I think, to have that information. I think having a sheet like they do in Pennsylvania is great, because it does take an extra 1 minute to do, but it's something that can go with the patient, and it's something that we can all look at, and we have the exact data that we need. And like you said, also, the people in the hospital don't understand what the people pre-hospitally are doing. The people pre-hospitally don't understand what's going on in the hospital. And until we have the EMTs and paramedics working in the ERs with us, and until we have all of our doctors and nurses going on the trucks and working with us out there, there's just a difference in culture. There's a knowledge gap, and it's hard sometimes to communicate in that regard. And having something that's standardized, I think, is definitely useful for patient flow, and also so just things don't get repeated over and over again for the same patient.
Yeah, I think the last time I delivered a patient, I gave a report 10 times.
Yeah.
To 10 different people. Actually, no, probably 6 different people, because I gave the same report to the same person more than once. And that's why, we did, back in September, we reviewed a study, I think it was specifically for trauma, where they had a protocol. A trauma code would come in, the trauma team would convene. They actually had it printed in a humongous poster right in the trauma bay, and it said, this is how this is going to happen. So before the patient was even transferred to the gurney, you pull the patient up into the trauma bay, everyone stops everything that they're doing, and then focuses on the lead paramedic and gets the report. And, whoever's in charge of running the trauma code will say, begin.
Yeah.
And it would be like, this is how we found them, this is what we did, this is what happened. Any questions? No questions? All right, let's move the patient over now.
The trauma bay at UPenn, actually there's a star of life on the floor, and that's where the paramedic will stand and give his report.
Is there a beam of light as well?
No, but it's awesome, it's true, and we need to take that time, and when we're running the resuscitations and we're the ones who are in charge, it's important, I think, to have everyone stop and take that 1 minute or 2 minutes to hear what's going on in a unified fashion. It's so frustrating when we walk into the ER, when I'm working pre-hospital, I walk into the ER and then have to give the report 5 or 6 times to different people as different people are running in and out of the room. Like, I have stuff to do. I gotta leave, get ready for the next call, wrap up my equipment, and to just give the same exact information over and over and over again, it's a lot. And once we start doing something, people can't pay attention. It's impossible to listen and move the patient and disconnect him from the monitor, hook him up on the monitor. It's starting to get IVs put in. It's too difficult, I think, to be able to. I mean, you can listen, but how much are you actually hearing at that point? So I think, like you said, just taking that time is
it's not
essential.
just listening, it's focusing on what's going on. And in reality, it probably takes less time to do it that way.
Yeah.
I know that there are companies out there. I don't actually remember their names, so I can't really endorse anyone, and nor I would, because we don't have any affiliations. But I know there are companies where, from the pre-hospital provider, you can record a video or a voice, basically like a voicemail, send it to your online medical control, send it to the receiving facility, and that is just like a packet where you can access it at any time. So as an ER physician, the patient who was dropped off 30 minutes ago, you can actually get first-hand report. Now, that report has to be a good report, because you really can't ask any questions, but there are companies out there who do that. The problem is cost. They do understand that it's going to be on the facility side, but to get a facility to invest in that technology when no one is saying that this is a problem, even though everyone knows it's a problem.
And it really affects the provider side too, right? You get this person that, and all that knowledge just played telephone, and it gets distorted. And especially from the paramedic side, you were there, you saw what happened, you know the house. When they come to us as the ear provider, they come in as headache. But everyone along the way missed the fact that, all the carbon monoxide alarms were going off, and the fire department evacuated the house, and that's why we have 5 headaches. And that's never conveyed to us, and it totally changes the diagnosis, the management. It's really important. I'm a huge supporter of the paper and it follows the patient. You can go back and look at it. I think it's really important.
And I mean, the system that, where I initially saw it before it was presented at NAEMSP it was a hospital-based system, so that was actually, that form became part of the patient's medical record as part of the pre-hospital record. So that followed the patient throughout the hospitalization. So, I mean, what was reflected in the ED chart may not have incorporated all that information, but if someone wanted to look at, hey, pre-hospitally, they said, this is what someone said EMS reported a blood sugar of 20, but I don't see anywhere where it says that. And it's right there in the pre-hospital portion of the chart. So I think the fact that it follows these people through, I think, is something that's relatively easy to do. I think as medical directors, physicians, medics, nurses, everybody, there's plenty of room for for coordination between all these different groups to be able to do these things. So if you're a medical director of an emergency department, is that a protocol that needs to be in place? You need to educate nurses, medics that work for the hospital, whatever it may be. Where can you make an impact to help improve the patient care? I think it's something, from what I can gather, relatively easy to do. So again, it's kind of recognizing the problem or identifying the problem, coming up with a solution, testing it out, just reassessing, see, does it, from my thought, it can't negatively impact patient care. So,
I mean, there's so much information that gets lost from the pre-hospital setting. How many chest pain patients do we see? Do we know if they got aspirin pre-hospital or not? How many asthma patients do we see? Did they get the Solu-Medrol or not? You know, fine, we give someone extra dose of Solu-Medrol, we give someone extra dose of aspirin. It's not the end of the world, but there are certain interventions that if we do them multiple times, or if we don't do them because we think they were done, then it will impact the patient.
It can cause harm, yeah.
And like you said, this stuff, the doctors, we rarely will speak to the paramedics, and I think it's a big loss for the patient because we have someone else who's deciding what's important to put in that chart that, you know, who may be stressed out. You know, there's 10 ambulance patients waiting at the door, and all of a sudden it's like, okay, let's get these people through as fast as possible. I'm going to wait, you know, the least amount, or I'm annoyed, or I'm having a bad day, or the paramedic's having a bad day, or whatever it is, and just information not getting communicated. And even on a sheet of paper, having something as simple as, you know, what do you think is important in the care of this patient, or what do you think is important to convey to the ER, is something that could definitely make a big difference. And a perfect example, what you see, the carbon monoxide reminded me. I walked into this patient, it was like a syncope or something, and I walked in, the first thing I noticed, the whole house smelled like gas. And I go upstairs, I'm like, all right, I want to get out of here, you know, like, it smells like gas. And the fire chief actually turned to me, he's like, you think it smells like gas in here? I'm like, yes, I do. I'm glad I'm not the only one who thinks this. So whatever, I knew, we got the patient out, and she got transported to the hospital. They ended up calling more people from the fire department, and, you know, they evacuated the house. And then as I was, you know, the paramedics transported to the hospital, and then actually I called the ER, because I was curious to know if this information was conveyed, that the whole house smelled like gas, and it was, and the house was evacuated after, and the ER had zero idea about any of that.
The same thing happened to me yesterday on the clinical shift with carbon monoxide.
Yeah.
It never got conveyed.
And it's like there's so much information that, you know, at different, you know, and sometimes there's so much information pre-hospitally that really will make a difference. And just having that whole kind of picture of seeing where the person is, we're bringing them into a, you know, sterilized environment, so to speak, where we just don't, where we lose so much of the context of whatever was going on with that patient. And unless we're, you know, unless
the hospital says, oh, no one ever told me that, was it written down? Is that something that they felt was pertinent? If not, it's an opportunity for education. Say, hey, you brought 5 people in, all of them had a headache, and you didn't relay the fact that the whole house smelled like gas. That's an area for improvement for education. So I think that is something else that you can use it, not just in the patient care immediately at the hospital, but also for follow-up, providing appropriate feedback, and educating everyone involved in the patient's care. So, and then it kind of extends further. If you're the receiving facility, you don't have that information. Is it because you missed it, you didn't listen, you were trying to multitask, and didn't take the time to listen because you had other things on your mind? But even though the information was relayed, it never get relayed. And that's something that having that sheet of paper or something, some form of immediate concrete feedback or some kind of information, I think would be helpful for just kind of all around looking back at it, doing chart reviews, things like that.
Yeah, I remember always leaving my PCR that you couldn't read because it was triplicate. And then someone always complaining that, oh, no one ever left it. I'm like, I put it in the chart myself. So, I mean, it's great that we're moved to electronic, but, you know, the electronic version is, you know, you have to submit within 24 hours, which is well beyond my length of stay in the ER. So,
Yeah.
next article. Unless someone has anything else to comment about transitions of care. And I think we talked about a lot of the issues, and it's going to be an issue for a while until we figure this out. I know that in some places, to help decrease the burden on the paramedics, some agencies have actually hired dictation service. So, you know, while your partner's cleaning the wig, you just dial the number and say, this is paramedic 1234. Remember this, patient so-and-so, 73-year-old male, presented like this, and by the time you get to the rig, it's already dictated within less than an hour, and you click sign, and a copy gets sent to your agency, and a copy gets sent to the ER.
It's pretty cool.
It's pretty neat.
That sounds cheap.
But it may be expensive up front, but the time that you may save on the vehicle being out of service and the unit hour utilization, all that kind of stuff, it may pay off.
Think about how much time you waste at the hospital doing, okay, I need to finish this chart, or, you know, you could be helping to clean or going back in service. And then also the decreased stress on the medic to have to, like, finish their charts and all this. And also the extra detail that you're going to get because they're dictating, they're not writing or filling in boxes or clicking on little tiny boxes, right?
Yeah, I guess the one thing you risk with that is, like, you know, maybe there's required information that you want to get that then gets missed, or maybe there's a
So
way
just
to
like we
figure
do,
it out.
I don't know where you guys did surgery, but when I did surgery, we had a book of macros. So it would have bullet points of what you need to address. So you need to put the date of birth, you need to put the patient's name, you know, what the indication for your procedure was, who was in the procedure with you, who was assisting you, and then your post-exam, you know, was there a, you know, a count? Did you count to make sure all the gauze was out of the patient before you sewed up?
Yeah.
You know, and it could just be a bullet point. And then they have full macros where you just read and they're blanks where you fill in what's pertinent to that patient. All right, next article.
All right, we can do Cincinnati pre-hospital stroke scale can identify a large vessel occlusion stroke. I just thought that was an interesting article. I mean, we all, from EMT school, we all learn about the Cincinnati scale, one of my favorite things to do pre-hospitally. You know, it's just comprised of 3 things. It's basically scaled from 0 to 3. If it's 0, then there's no deficits basically. 1 point is given for each of the following physical exam findings. If there's facial droop, they get 1 point. If there's arm drift, they get 1 point. If there's slurred speech, they get 1 point. So the question here that they're asking is, can we use the pre-hospital Cincinnati stroke scale to predict a large vessel occlusion? And the reason why we would want to know this is because now that we have comprehensive stroke centers versus just primary stroke centers, where we're doing some endovascular therapy, should a patient who has a large vessel occlusion, who may be a candidate for thrombectomy, basically, should they be transported to a comprehensive stroke center versus a primary stroke center? And then, if so, then how are we able to pre-hospitally determine that? And I think this actually has a lot of implications, you know, on the hospital levels, because based on reimbursements and everything, and if we're bypassing closer hospitals, then, you know, certain hospital systems may say, well, why don't you bring your patients to me? So I think that's one implication. And then the other implication also pre-hospitally, do we want to go for a longer transport time, take a unit out of service for longer, and bypass closer hospitals to give people a potentially higher level, a higher level of care? So those are kind of questions they're asking. And the other issue is that we have other tools that we can use, like the NIH stroke scale, or it's a bit complicated and it involves a lot of training, and there's probably going to be a lot of variability, especially on the pre-hospital level, where things are changing so rapidly, and it's hard to keep track of so many providers, especially in really big systems. So this is something that they thought that they could use, because everyone learns this from day one basically in EMT school, and it's pretty well accepted. So what they did was a retrospective analysis on patients in the Northwestern University Brain Attack Registry. They were admitted to a single high-volume comprehensive stroke center, and it was a single municipal EMS provider that basically responded to all the 911 calls. And what they looked at was if patients who had 1, 2, or 3, if it predicted that these people had a large vessel occlusion, basically. So they correlated this with the primary outcome is basically the presence of large vessel occlusion on head and neck vessel imaging using the first study that was done, whether that be MRI angiography or CT angio or just regular angiography or ultrasound duplex. So how they define large vessel occlusion was basically complete or near complete occlusion of the intracranial internal carotid artery, the middle cerebral artery, M1 or M2 segments, anterior cerebral artery, A1 segment or proximal A2 segment, the basal artery, posterior cerebral artery, P1 or P2 segment, or the intracranial vertebral artery. So what they found was that the optimal Cincinnati pre-hospital stroke score to predict an LVO was 3, basically. So they found that the odds ratio for people who had 3, the unadjusted odds ratio was 5.1. So 5, and then was 5.1, and then when they adjusted for age, sex, and race, that it was 5.7. So the patients that had the CPSS score of 3, 72.7% of them had a large vessel occlusion, compared with 34.3% of patients with a CPSS of 2 or equal to 2 or less. And there was a false positive rate of 11.8%. I think it's important to talk about false positive and false negative in this because of the implications that it has. So if we're going to design a study and design this and design a protocol pre-hospitally that has a large amount, let's say we get every single person who has a large vessel occlusion, and we want to, we can have a very, very high sensitivity and say, okay, well, we're catching 100% of the patients that, we're catching 100% of the patients that have it, but how many false negatives are we going to have then at this point? If we had everyone who has true positives, right, how many, and then are we catching way too many people, basically? We want to get all the true positives, but we don't want to get the negatives that we're bypassing the other centers that people aren't going to be able to get intervention on. So it's important to, when designing this, to think about the sensitivity and specificity and the true positive rates and the true negative rates that we're getting. So they think that the CPSS score cutoff of 3 strongly predicts LVO, which it seems like it does. I think this has a bunch of implications in EMS and the emergency departments, as we kind of spoke about. This is only done in one study, though, in one system, so it's something to also think about. I think there are other studies out there that they kind of mention the Cincinnati Stroke Triage Assessment Tool, which involves eye gaze deviation and ability to follow commands and arm drift. That found to have a sensitivity of 71%, a specificity of 70%. There's a Los Angeles motor scale, a rapid arterial occlusion evaluation. So there's a couple of different scales out there. But I think this is, as our care is evolving in the stroke world and as we are having more comprehensive treatments, I think these decisions that get made on the pre-hospital setting have bigger and bigger implications, because also transferring a patient is no easy task sometimes. We've got to call the receiving hospital, you got to get the ambulance to come back, get an ambulance to come to the hospital, transport them, and what, is an extra 5 or 10 or 15 minutes on the front end may save someone hours on the back end by the time the whole workup gets done. And, and the question is also, going the extra 5 or 10 minutes, it's possibly delaying the TPA that would be given, so there's a lot of questions that kind of go into this stuff, but I think it's good to definitely talk about, especially as we're seeing more comprehensive stroke centers. So.
I think all this stuff is massive indication creep in terms of the effectiveness of endovascular therapy. Like, I think this study does a good job at comparing Cincinnati to other scores in and of themselves, but I'm not surprised that it does a good job of determining large vessel occlusion, because if you have a dense hemiplegia, you're aphasic, and you have all these things that are consistent with a large vessel occlusion, I'm not surprised that they screen and find a lot of people who have a large vessel occlusion that have all those things. But I think that the assumption that these patients are going to then be candidates for endovascular therapy, which all the major trials show that there's less than a patient per month who benefit from this intervention per facility. I think restructuring the entire EMS system and in order to potentially derive a benefit for a treatment that's questionable at best or needs more study for a specific inclusion patient population is kind of an indication creep. It's a far stretch, in my opinion. I don't.
So one of the issues that we've had, there's talk in New Jersey about revising the stroke guidelines to bypass primaries for LVOs and take them to comprehensives, is what scale to use, because there's 5, 6, 7 different scales. And the paramedic program's feeling is, we don't care what scale you want to use, give us one, so we can train everybody in one. Well, everybody's already trained in Cincinnati. BLS, ALS, it doesn't make a difference. So would this study be enough to say, we'll just use Cincinnati, and if our patient is a Cincinnati 3, they meet the qualifications for an LVO, go to a comprehensive. We wouldn't have to worry about the Men's or Miami or NIH or anything else on these patients. Everybody's already trained in it. It'd just be a matter of tweaking it a little bit to understand it a little bit more.
Like I think you said, it is important to see, right? Should we be doing these endovascular therapies? Like, are we bypassing other centers to do an intervention that
Could have been done just TPA.
Right, that could have just gotten TPA, and I think that's a question that we may not have the answer to at this point as well. And I think as time goes on, this may have more implications.
Yeah, we need more patients, more data, more studies. I try not to change any practice based on one study, unless it's a freaking good study. But even then, you want to see if it plays out. Do you have time for one more article? Chris, do you want to talk about something, or
Yeah.
the VL review maybe, or?
I was going to do ketamine. What else do you want to do?
Oh, we
It's
love
kind of a hot
We always love
topic.
ketamine.
So this is the use of ketamine for acute treatment of pain, a randomized, double-blind, placebo-controlled trial. And so they, give their background saying that, ketamine is an MD receptor antagonist. Subdissociative doses of ketamine have been shown to be beneficial for management of pain, and in the setting of the opiate epidemic and everything else, anything that's a non-opiate alternative to pain control sounds appealing. So what they did, single center, prospective, randomized, double-blind controlled trial, and they looked at subdissociative dose ketamine in adult patients who presented to the ED with acute pain. The dose that they used was 0.3 mg per kg, and they, importantly, because it distinguishes it from some other studies as well, they ran this in basically as in 50 cc's. It wasn't a bolus dose; it was dripped in. And so the other thing that they did as well is these patients also received a dose of morphine as well, which makes it different from some of the other studies that are out there as well. So they weren't looking at necessarily ketamine versus morphine itself, but they were looking at pain control at various time intervals after morphine was administered, and then ketamine as well. And so really the treatment group was ketamine versus no ketamine in a population who had already gotten morphine. And so just something to point out as well for them, they defined this acute acute pain to be greater than or equal to 3 on a scale of 0 to 10. So, I don't know how feasible that is in terms of identifying a patient population that's in, a lot of discomfort requiring a lot of pharmacologic intervention and control. A 3 out of 10 might not be that specific population, so it's something to keep in mind as well. So what they did, they looked at 30 patients in each group, and then they looked at pain control basically at 15-minute intervals. And their take-home conclusion basically is that subdissociative dose ketamine administered at the pre-specified dose over 15 minutes resulted in safe and effective analgesia for under or equal to 30 minutes in patients presenting with acute pain. So really, I think this study doesn't refute. It doesn't say that ketamine isn't useful. It's just that I question the actual study design. So they're looking at 15-minute intervals. They're saying that pain was controlled under 30 minutes. Both of the intervention arms had received morphine as well, so it's kind of hard to extrapolate. Like, is ketamine really beneficial in these patients? Can it replace morphine? I don't know the answer to that question based on this study. They didn't really see any significant adverse events, which is good as far as a safety profile for ketamine. But in being able to determine is this ready for prime time? Is this something that's great for pain control or everything else? I think a lot of their methods kind of preclude us from knowing all those answers. And you compare this to like the Sergei Motov study, I think that came out a few years ago in Annals, where they looked at ketamine versus morphine itself. That's something more tangible, at least to me, to say that ketamine, is either non-inferior or has some other effects that are beneficial that I'd want to replace my current prescribing habits with using ketamine.
Did you see whether or not they separated the pain score, or is it just anything above 3?
It was anything above.
Anything above 3.
Yeah, because even when, from when we put in orders, like standing orders for PRNP medication, it's like pain 1 to 3, 3 to 5, 5 to 10. So there's like a range. So I would have liked to see them separated. So pain above 8, did this help? I think it's fine that the baseline was morphine. Because we do, especially with the opioid crisis, you want to reduce the amount of opioids we prescribe, the opioids that we use. Could we even just ketamine, ibuprofen, ketamine, ketorolac, something like that would be beneficial. But it's definitely a step in the right direction. I know that we're trying to get ketamine for pain in our institution, and who knows, maybe one day pre-hospitally, but we're baby steps.
What are you doing for pain? What are you guys doing when you have someone who comes in with a broken bone or something and you're discharging them? What alternatives do we really have at this point? On the discharge side, we can give ketamine in the ER for it, but then what do we do?
In terms of fractures, things like that, there's only so much you can do. We used, when I was in the trauma service, we actually used a lot of lidoderm patches as kind of an adjunct centrally acting skeletal muscle relaxant. So we used Rivaxin and Flexeril, whatever it may be. So we kind of we worked with a clinical pharmacist to kind of come up with a pain regimen and minimize the opiates. So the first thing we would do is kind of taper them off the opiates, and then we would leave all the others, and the next thing would be the muscle relaxants taper off. But we actually looked at how little additional doses they were looking to get off their basal rate from when they were on a PCA. Once you put the lidoderm patch on, they had a significant reduction in how much PCA they were using in terms of their bolus doses. So I started using it more after doing that rotation. Rib fractures is where I think it's been where I've seen it the most in terms of other extremity fractures. I use it here and there, depending on the situation, but I can't say.
You have a pass on something.
That's the thing is, in terms of the ED, you can put a lidoderm patch on. Depending on where it is. If they're in a splint, they're going to see somebody if it's middle of the night, they're going to see somebody that morning. You can put a lidoderm patch on, but even then, they're only on for 12 hours. So the feasibility of it long term.
I'll also use nerve blocks to help adjunct. the need for heavy doses of pain medication, especially if you have a displaced fracture. Once you put the fracture back, generally the pain is much improved. So if you dose them with morphine, fentanyl, now that stimulus is gone, now they start falling asleep, or you hope that they don't stop breathing, and that's the big part on why. Pre-hospital, we're kind of limited, and I think we have a pretty decent system where we have fentanyl, we have ketamine, we have different options. But there are other systems where they have no options. They have morphine, Versed, and that's it. And if you want an RSI, you also have morphine, Versed. That's it. So it's definitely something that we want to look for in the future to help, because controlling pain for our patients pain is significant, and that's sometimes the only reason why they're calling us. I know IV Tylenol, not that I'm endorsing Tylenol, has become an option, possibly Toradol, but these are things that everyone has to look at in their own institutions and their own pre-hospital programs and see whether or not that's a viable option.
There's a pretty big cost factor to the IV Tylenol.
It's now $40.
Huh?
$40 now.
That was an issue when we first started looking.
It's been very expensive, but not expensive.
It used to be a couple extra zeros. And now it's per dose. All right, I think that wraps it up for this journal club. Check us out on Facebook. Check us out on the website. We post these videos also on YouTube. And, every day we're trying to improve, so let us know if we can do anything. We're sorry, we apologize for the technical difficulties. Of course, we always have a busy schedule, but let's see, is there anything coming up? We just had our Jacoby outreach this morning. Hello to the Jacoby residents. We're going out to some of the other places as well. And that's it.